This video provides a basic overview of radiographic techniques and demonstrates how to set up and perform an X-ray procedure. Equipment required for the conventional radiography procedure includes the following: a generator, an X-ray tube, tracking measurements on the X-ray tube column and ceiling track for source-to-image receptor distance, an image receptor, such as an upright bucky, an adjustable collimator, a radiographic table with a floating top, which sometimes can be moved up and down. Movement of the table is controlled by a foot switch or bar, compensating filters of different types, lead or radio-opaque image markers, lead apron for caregivers or staff who need to remain in the room with the patient, patient radiation protection shields, lead blockers for multiple images on a single cassette, positioning aids such as radiolucent sponges and sandbags, anatomical position-enhancing aids such as weights, bed linen and towels, a control panel behind a lead-lined screen. Conventional radiography, using film and intensifying screens, is slowly being replaced by computed radiography. This involves a digital image acquisition system and includes all of the equipment used for conventional radiography, as well as the following: imaging plates and cassettes of varying sizes, a technologist workstation, which includes a computer system, an image plate reader or processor, and a picture archiving and communication system, commonly known as PACS. To prepare the X-ray room, switch on the X-ray generator, computer workstation, and X-ray equipment in the room. Warm up the X-ray tube at the beginning of each day or after a break of 1 hour or longer to protect it from damage. Activate the rotor with the prep button and make a sequence of exposures. Ensure a safe and clean working environment and that there are adequate supplies of linen, patient radiation protection shields, and lead aprons. Ensure you are suitably dressed, including an ID badge that clearly indicates your name and your employer's name. A radiation badge must always be worn, usually at waist level. Introduce yourself to the patient and confirm the patient's identity. Explain the procedure, patient rights, and confidentiality. Confirm the reason for the examination and obtain a brief medical history. Rule out the possibility of pregnancy in all female patients of childbearing age. Show the patient to the changing room and ensure that they are suitably clothed and not wearing any accessories that could obscure the radiographic image. Remember to wash your hands both before and after the procedure. The image receptor consists of an upright bucky with automatic exposure control, or AEC photocells, a radiographic table bucky, which also has AEC chambers, a cassette on the tabletop, or a portable grid with a cassette. Both upright and table buckies contain a moving grid that reduces the amount of scatter radiation reaching the cassette, and a pull-out tray into which the cassette is loaded. Image plates can be of varying sizes. The most commonly used sizes are 10 by 12 inches and 14 by 17 inches. Inside the bucky cassette tray is a measurement guide to help ensure the proper positioning of the cassette. Once a cassette is correctly placed in the middle of the tray, it must be locked into position so that it does not move during the exposure. Most bucky trays contain a lever to lock the cassette in place. There are several positions that are commonly used for radiographic imaging: supine, where the patient lies on their back; prone, where the patient lies face down with their arms at their side; and erect, which is an upright position where the patient may be standing or sitting. Specific body positions also may be used. These are described by the body part closest to the image receptor or by the surface on which the patient is lying. For example, a decubitus position in which the patient is lying down and the X-ray is projected horizontally toward the image receptor. The central ray is the part of the X-ray beam that has the least possible divergence and therefore the least distortion. The central ray is aligned perpendicular to the center of the image receptor. For certain projections or body parts, a specific angle may be required, so the central ray can be angled in a cephalad direction, meaning toward the head, or in a caudad direction, meaning toward the feet. The source-to-image receptor distance, or SID, is the distance from the X-ray tube to the image receptor. The SID is the first controlling factor for distortion, as the greater the SID, the less the magnification. Collimation limits the area of radiation administered to the patient and also reduces the amount of scatter radiation reaching the image receptor. Accurate collimation reduces patient exposure by limiting the size and shape of the X-ray beam to only the area to be visualized on the image receptor. Radio-opaque markers must be placed just within the field of collimation so that they are exposed and included in the final image. Markers should not superimpose on any anatomy. The R for right or L for left marker indicates the orientation of the patient for the projection. The markers are placed directly on the image receptor on the inside of the lateral portion of the collimated border, on the side being identified. It is important to provide the patient with clear and precise instructions. Patients may be given different instructions depending on the procedure requirements, such as remain still, breathe in and hold your breath, or put your arms up. If asking the patient to hold their breath, remember to inform them at the end of the exposure that they may relax again. The exposure factors determine the amount of radiation and the length of exposure time of both the patient and the image receptor to the X-ray beam. When selecting the exposure factors, it is important to consider whether a Bucky or non-Bucky system is used, and whether a large or small focal spot is required. Exposure factors also include the kilovoltage, or kV, and milliamp per second, known as MAs, which are determined by the thickness and density of the body part being examined. All radiographic projections will be taught using the mnemonic IMAGE, where I represents the initial setup, M the manual exposure factors, A the anatomical positioning, G the guidance of the central ray and collimation, and E the evaluation of the image. For the initial setup, select an appropriately sized cassette. This will depend on the type of projection, the anatomy to be visualized, and the body habitus of the patient. Orientate the cassette lengthwise or crosswise and place it in the upright Bucky, the table Bucky, or on the tabletop. If using an upright Bucky, adjust the image receptor to the height of an average person and direct the central ray toward the image receptor. Set the source to image receptor distance, SID, which is usually either 40 inches or 72 inches. Turn on the collimation light. Align the central ray to the image receptor and collimate to the size and orientation of the cassette being used. If using a single cassette for multiple projections, divide it into sections with a lead blocker. Manually select the appropriate exposure factors on the X-ray console. Some X-ray equipment provides the option of pre-selection of exposure factors suitable for the anatomy of interest and the projection being undertaken. To position the anatomy, instruct the patient to sit, stand, or lie down, depending on the requirements for the projection. Place a lead shield to protect the patient's reproductive organs as appropriate. Align the central ray to the body part by adjusting the position of the crosshairs. Adjust the image receptor to the central ray. Collimate the light field to include the necessary anatomical structures. Place the appropriate lead markers within the field of collimation. Position yourself behind the lead screen and adjust the exposure factors according to the patient's body habitus. If necessary for the projection, instruct the patient regarding breathing technique. First, prepare the anode and then expose the image receptor, or IR. Once the exposure is complete, inform the patient that they may relax and breathe normally. Remove the cassette and transport it to the ID station or reader. Ensure that the image is identified with the patient details. Insert the cassette into the image plate reader. Once the plate is scanned, remove the cassette from the reader and review the image. Critique and assess the image quality according to standard criteria. Anatomy required, the correct anatomic parts and structures are included. Position criteria, the body part is correctly placed in relation to the image receptor and distortion is minimized. Collimation and central ray, the collimation borders in relation to the body part and location of the central ray. Exposure criteria, assess the detail, contrast, and density of the image and check that there is no motion artifact. Image markers, anatomic side markers, patient position markers, or time markers are correctly placed. When satisfactory images have been obtained, send the images to the Picture Archiving and Communication System, or PACS. There are a number of different projections that can be used for radiographic imaging. The postero-anterior, or PA projection, is where the X-ray beam, or central ray, enters the posterior aspect of the body or body part and exits anteriorly. The antero-posterior, AP projection, is where the X-ray beam enters the anterior aspect of the body or body part and exits posteriorly. When the body is rotated medially or laterally, this is called an oblique projection. It is a projection in which the central ray enters the body or body part at an angle following an oblique plane, while the central ray remains perpendicular to the IR. A lateral projection is one in which the X-ray beam enters on one side of the body or body part and exits on the opposite side. Trauma patients require major adaptations of the standard projections. In particular, the angle of the central ray and placement of the image receptor must be adapted to accommodate a patient presenting on a stretcher. Most projections are obtained with the patient remaining in the supine position, which requires the use of a vertical bucky or stationary grids for cross-table laterals. In the case of pediatric patients, the radiologic technologist's attitude and approach to the child and guardian, as well as the technical preparation in the room, are important. Pediatric patients need the same basic X-ray projections as do adults, but care and attention to communication with both the child and the guardian is important to obtain optimum images. It is essential to either enlist the guardian's help to immobilize the child or to use immobilization devices such as sandbags, bandages, or tape in order to maintain the correct position. Caregivers must wear radiation protection if they remain with the child during X-ray exposure. A skeletal survey is a series of projections of the large bones in the body such as the bones in the chest, long bones, skull, spine, and pelvis. The survey is commonly completed for multiple myeloma, metabolic disorders, and non-accidental injury, or NAI. At the end of the procedure, advise the patient that they will receive the results of the radiographic examination from their referring physician. Take the patient to a changing room to get dressed, and then escort them out of the radiology department. Wipe down with disinfectant all surfaces, including handles of the cassette, bucky, X-ray tube, and collimator. At the end of the day, shut down the X-ray equipment and computer system. There are some general professional considerations that all radiologic technologists should adhere to. Radiography students must attend a school accredited by the Joint Review Committee on Education in Radiologic Technology, JRCERT. Radiologic technologists are expected to be credentialed through the American Registry of Radiologic Technologists, ARRT, and licensed in their state. The technologist must be aware of their responsibilities to the patient in relation to Health Insurance Portability and Accountability Act of 1996, HIPAA, and the Patient's Bill of Rights.